When it comes to primary and secondary prevention of atherosclerotic cardiovascular disease, or as patients know it, heart attack and stroke, due to cholesterol-rich inflammatory lesions in the arteries, statins continue to be the mainstay of therapy. This, of course, is in addition to lifestyle therapy and attention to all those other important risk factors. But today we're going to focus on some helpful hints to help the clinician and the patient in their risk discussion make that shared decision about taking a statin successfully. I'm Dr. Neil Stone. I'm the Bono Professor of Medicine, the Feinberg School of Medicine. And along with Dr. Sean Ragwani and Jennifer Manning, we were pleased to have this article, Top 10 Tips for Using Statins in Clinical Practice, accepted by Mayo Clinic Proceedings. It's going to appear in the December issue. We compiled a series of 10 tips after seeing patients in the clinic who seemed more confused when they came into the clinic about taking statins, and hopefully they were a lot better shape when they left. We focus particularly on the clinician-patient risk discussion. This has been mentioned in the last several guidelines, and it's very important in those areas where there is not the strong evidence that you see for secondary prevention, high LDLs above 190 on a primary basis, and in diabetes. But in those adults 40 to 75 who have a high risk score or a high likelihood of having coronary disease or stroke at an earlier age than desired. We point out that it's very important for the clinician to emphasize to the patient, who often comes in with preconceived notions, that they know something that's not on the internet, and that is how the benefit of this therapy would pertain to the patient, and specifically the patient's risks for side effects. In other words, very patient-specific therapy, and the ability to point out that a wealth of data, angiographic studies showing reduction in angiographic volume, population studies showing a reduction in heart attack and stroke, all show that the LDL reduction and the ApoB reduction seen with statins lead to benefit both in heart attack and stroke rates in proportion to the reduction in LDL and the cumulative duration of those arteries' exposures to the lower LDL. Thus, it's not just lower, but lower longer. We particularly focus on having clinicians build rapport. We'd like to have the physicians see this discussion as a kind of negotiation where you try to find common ground, you try to listen to the patient's concerns, and then you point out how specifically the statin could benefit the patient in terms of lowering their risk. We also think a family history is especially valuable, not only in terms of whether there's premature heart disease or premature elevations of LDL cholesterol, but also in some families, they don't tolerate certain statins. And if you find out, for example, one family, no one tolerated simvastatin, well, that's obviously not a statin you might want to use in this person. There could be a very good reason for why that is true. And so we ask people to create a patient-specific plan, not just a prescription. I like to tell people, which hand do you want to cut off? The hand that's offering you the statin, or the hand offering lifestyle and attention to other risk factors? I need both to help you lower your risk of a heart attack or stroke. And it's very important that the patients realize that this is part of a program. It's not just simply just a drug that lowers LDL. There are a lot of drugs that lower LDL, but only a few have been shown to not only lower LDL, but be associated with net total benefit in terms of heart attack or stroke. It's important in what we wrote that clinicians talk to the patient about what other medications they're on, looking for drug-drug interactions, and we go into that in some detail. And we go into discussion on statin-associated muscular symptoms. We emphasize the importance of location and timing, and to be aware of the fact, and we mention this to patients, that a high proportion of patients who sometimes have symptoms after they start taking a statin have pill anxiety. This is very common. A high proportion of patients in double-blind randomized trials were found to have the same symptoms on placebo that they had on statins. So it's very important to get a very specific history. Is the discomfort bilateral, involving proximal and large muscle groups? Is the onset soon after taking the statin and resolving with discontinuation of the statin, or has it come and gone at various times? And we point out ways that doctors can be a little sharper about that. We also talk about recognizing severe symptoms that can be associated with a statin that every clinician needs to be aware of, that are very rare, but clinicians should know about them. And lastly, we really emphasize this de-challenge method. This was pointed out in 2013 and again in 2018, and we still find it very helpful where patients are unsure of whether their symptom is a statin. We say, let's go off for 3 weeks and then re-challenge with either half a dose or another statin and see exactly whether the symptom occurs. Very often it doesn't. And then lastly, I want to point out that we talk a little bit about patients over 75. Patients over 75 in secondary prevention should feel very good about taking their statin, because we've got a lot of patient-specific data showing the benefit of statins in that group in secondary prevention. Whereas in primary prevention, those without a previous history of heart attack or stroke, the jury's not in. We have some large clinical trial data that's coming in, and we need to find out just how solid the evidence is. Patients already taking statins in primary prevention who have multiplicity of risk factors may want to continue, but that's an area where we need further research to help us decide just whether or not a statin intervention makes a lot of sense. I invite everybody to read the article and see what they think of our top 10 tips.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.